I want to welcome everyone to the next segment of our Stepping Forward Together parent focused series. On this segment, we're going to be featuring an orthopedic surgeon's perspective to really talk about the diagnosis, what clubfoot actually is, and then what the aspects of treatment are from a surgeon's perspective. So we are so grateful to have Dr. Anthony Riccio here with us today. And he is the medical director of education and director of the Center of Excellence in Foot and Ankle Deformity at Scottish Rite for Children in Dallas, professor of orthopedic surgery at University Texas Southwestern Medical School, and adjunct professor of surgery at the Uniformed Services University of Health Sciences. He specializes in the treatment of clubfoot and other foot deformities, as well as limb lengthening and reconstruction. Thank you so much for being here, Dr. Riccio. I'm so excited for you to be here.
Thanks, Maureen. I'm thrilled to be here. Thanks for having me.
Yeah, so we're going to just jump in to a bunch of questions. So these are kind of FAQ questions that are typically I hear and that we've heard from the Clubfoot community, parent focused. So we'll just dive into those. And the first just being, can you explain clubfoot in technical terms, but also in language that parents can understand, what it is exactly and what aspects of the lower leg does the deformity impact?
Sure. So what I tell all parents when I see them for the first time is that the most important thing they need to understand about a clubfoot deformity is that a clubfoot is not a normal foot on the inside that was just pushed and squished into an abnormal position on the outside. It can be a pretty dramatic deformity when parents look at it. And so from a basic standpoint, outwardly, the foot kind of looks like it's forced inward or turned kind of to the midline of the child, upside down in a way, and pointed down to the ground. And those outward deformities we see are a direct result of internal differences within the foot that don't just affect the foot, but it actually involve the entire lower leg. And so it's important for parents to understand that internally the bones are shaped differently than a child with a normal foot or the parent's foot. The soft tissues that hold the joints together, we call that the joint capsule. It keeps our joints aligned. It stops our joints from dislocating or subluxating, and it holds our joint fluid in. In you or me, Maureen, is very flexible and stretchy. I tell parents it's kind of like thick yoga pants. Like you can pull it apart, it's going to take some force, but there's some elasticity to it. Whereas in a child with a clubfoot, there's too much collagen and protein in those capsular tissues, which makes it very rigid. And so their capsule would be more like old-fashioned denim Wrangler jeans. You try and pull and there's no give whatsoever. Blood vessel anatomy is different in children with club feet. Many children with club feet don't have the normal number of blood vessels bringing blood to the foot, and those that do, sometimes they take an aberrant path doing so. And even on a kind of a histologic level, if you will, there's muscles within the leg that turn into tendons that control the way the foot moves. That oftentimes have too many contractile filaments, little filaments that slide over each other to generate a muscle contraction. And so because of that, those muscle groups can actually generate force at a superhuman level, if you will, which sounds awesome. That sounds like the child's gonna have a superpower, but in reality, the foot is just a very carefully balanced marionette puppet with strings that pull in, strings that pull up, strings that pull down. And if one of those strings pulls with too much force, it just overpowers the other muscles and create deformity. So it's a constellation of all of those things: the aberrant anatomy, the abnormal muscle pull, the contracture around the capsules, that leads to this outward deformity, which is, again, a foot that looks to the parent like it's turned inward, turned upside down, and pointed down to the ground.
Yeah, I feel like that's such a good explanation. And I think that parents also get it in their mind because we get this idea that that this is, at least from my perspective, a lot like this is a correctable thing. This is fixable. And so in your mind, when you hear that as a parent, you're like, okay, fixable means it'll be the same. It'll be cured. And I think it's as the more work that I've done and the further we've gotten into clubfoot treatment, the more I learn, it's like, yes, you can get a corrected clubfoot, but that doesn't mean that that the clubfoot goes away. That now her foot is the same as my foot, right? Or if it's unilateral, the clubfoot is going to be the same as her other typical foot.
Yeah, absolutely. And so that's why it's really important for parents to get their mind around the fact that there are internal structural differences that can't be changed that
Yeah.
lead to the outward appearance they're seeing. Now, we can correct the outward appearance they're seeing through the Ponseti method and serial casting, with a goal to take this foot that is turned in and upside down and make it right side up so that it fits flat to the ground and the child can wear whatever shoes they want, play whatever sports they want, have whatever job they want, and really never regard their foot any differently than they would a normal foot, which effectively makes it to them a normal foot.
Right.
But those internal differences are always there. So a clubfoot is always going to be, so let's say in a child with a unilateral deformity, that clubfoot's always going to be a little stiffer and move a little less fluidly than the normal side. In all likelihood, that foot will be smaller than the contralateral normal foot. For whatever reason, club feet tend to be smaller. And sometimes children with unilateral deformity actually wear a half a size or a full size shoe difference between their normal foot and their club foot. And even as you asked me before, what else is affected? Well, the calf muscles are affected really for unknown reasons. These children tend to have skinnier calf muscles on the affected side. Now, it doesn't seem to affect function. They can go to the gym, they can lift weights, they can get strong, they can run fast, they can jump high. They just don't hypertrophy muscle the way they could on a normal side, where if they worked out every single day, that muscle is going to get large. It just tends to stay small, but function normally.
Yeah, I feel like that's such an important part. So it's such a great description. Thank you. What is the Ponseti method and why is it considered the gold standard of treatment for clubfoot? I know you mentioned it, so.
Sure thing. So the Ponseti method is a system of serial casting or a technique that involves the use of casts to bring this foot from this upside down turned in position to a right side up and turned out position. And it involves applying a corrective cast. Typically, a cast is applied each week, and each cast, for all intent and purposes, corrects a different component deformity of the clubfoot. And those component deformities together make up the whole appearance of the foot itself. So we do a cast, say the first week, to take out the high arch of the foot that most children with club feet have. And then the second and third casts typically are used to bring the foot outward because it's turned in, and really more importantly, align some of the malaligned joints internally. That not only allows the foot to turn out, but also allows the heel that's turned in to swing back into a more normal position under the leg. And on average, it takes us about 4 weeks of casts to completely correct those hindfoot and midfoot deformities. Now, part of the Ponseti method involves management of a deformity I mentioned earlier, which is that the foot tends to be pointed down to the ground. Now, we call that, in the medical field, we call that equinus. And it's really hard sometimes for the parents to see that deformity until we start correcting the foot. But as the foot begins to be spun around, it becomes very evident that oftentimes the ankle is pointed down to the ground, sometimes fairly severely, almost like a ballerina standing on their toes. Now, in about 5 to 10% of children, we can use the casting method to stretch out the tight Achilles tendon in the back of the ankle and the capsular tissues that are contracted back there. But in the vast majority, 90 to 95%, what we need to do to bring that ankle from that pointed down position is a very small procedure, which we do in the clinic. It's part of the Ponseti method, or at least I do it in the clinic under a local anesthetic. Not everyone does. where we just take a teeny tiny knife blade it's so small it's used for eye surgery, and we just make a tiny little poke hole through the skin, and we actually release that tendon. We cut it in half under the skin, and that allows us to acutely bring the foot into a position through the ankle where it's pointed upwards, with a goal of achieving about 15, but if we can get more and more degrees of having that ankle turned upward. At that point, what we need to do is hold the ankle up. And as we bring the ankle up, of course, those tendon ends that we've cut spread apart from each other. We put a final cast on, and that cast stays on for 3 weeks. We don't change that cast in the Ponseti method. And what happens over those 3 weeks, because children have unbelieving healing potential, is that those tendon ends just grow right back together, but now the tendon's longer. And so now the foot can go both up and down rather than just being down. So again, on average, at least in my practice, it takes about 4 weeks to correct the deformity of the heel or the hind foot, the high arch, and the kind of deformity through the middle of the foot that turns the foot in. And then we do the tenotomy at that point, and we put a final cast on that stays on for 3 weeks. So on average, you can basically correct all components of the deformity using the Ponseti method in 7 weeks. Now, the Ponseti method doesn't stop there. It's a method. It's a treatment of the entire foot. And so to think that 7 weeks in a cast can overcome all of those internal differences that I already described and have it just stay there, it would be foolish. It doesn't. This foot's developed over 9 months in the womb. And so part of the Ponseti method isn't just getting the foot corrected, it's keeping the foot corrected. And that's really where the rubber meets the road. And that's where we use bracing to kind of maintain the correction we've achieved. It's every bit as important as the casting and the heel cord tenotomy, and it's part of the entire method.
Yeah. So why the Ponseti method over surgery? Like just full surgery like they used to do before the Ponseti method?
Yeah, before the Ponseti method was widely adopted, the only way to really create a foot that was in what we call plantar grade position, which effectively just means it's flat to the ground, was to do what we call a circumferential release of the foot. And we would make a fairly large incision extending, almost all the way out to the long bones of the toes, around the back of the ankle, all the way around the lateral ankle bone, that bone you feel on the outside of your ankle. And through that incision, we would basically lengthen or release all of the tendons that were holding the deformity together, the joint capsule between the tibia and the talus, which is the ankle joint capsule, and what's called the subtalar joint capsule, which is the capsular tissues that kind of connect our heel bone to our ankle bone. In addition to that, we'd also have to release the joint capsule between the ankle bone and then the main bone in the middle of the foot, both on the inside and the outside sometimes, and then even release some of the tissues that control the toes and bend the toes down or pull the big toe in order to really get correction. And we would do all that and effectively took the foot apart completely. And you kind of put it back into a normal position. You lengthened all these tendons so they couldn't pull it back into an abnormal position. And by lengthening tendons, you weaken those tendons. A tendon that pulls over a longer distance is a weaker tendon. And then you would kind of pin and use pins that would stick out of the skin to hold everything together. And you could create a foot that looked really good doing that. You could create a foot that looked awesome. The problem is because of the tendon lengthenings, they didn't have the power that they had before you did that surgery and moving that foot. And because of the intra-articular surgeries, the capsular releases, which were all around the ankle, the joint between the ankle bone, the heel bone, the joint between the ankle bone and the midfoot, you'd create stiffness within those joints. Any joint, anyone who's ever had surgery in their joint, be it a finger or a thumb, a knee for an ACL, knows that you never quite move exactly the same. And when you do that to every joint effectively, or the most important joints in the foot, you'd have a foot that was flat, but didn't move and was stiff. Scarring could be extensive. The foot did not move the same as it could if you didn't open the joints. And in addition to that, there were always some issues. This was done on kids who were typically around 9 months of age. You'd do it before walking age. and the bones didn't always tolerate the deformity correction. And sometimes some of the developing cartilage around the ossification centers that would turn into normally shaped bones, it didn't really develop right. And so you'd get some flattening of the ankle joint or some flattening of the joint between the midfoot and the ankle bone. And that contributed further to a lack of motion. And so we learned that even though the foot looked good, if it didn't move, it didn't work well. And far better off having a foot that might not look perfect, but moves normally with regards to living our lives, doing our activities of daily living, playing sports, fitting into shoes, having a job where you have to be on your feet. And so we've abandoned it because the Ponseti method allows you to get basically the same correction. It's a longer period of treatment, as you know. It's not a 2-hour surgery and then 6 weeks in a cast. There's a little more involvement on the surgeon and on the family to get it done. But in the end, you have a foot that looks good and still moves and is normally powered. And that's really important for kids with foot and ankle deformities.
Yeah, that makes a lot of sense. So what do you believe is the most important thing for parents to focus on during that first initial casting phase of treatment?
Yeah, it's tough for parents when we start out because they want to do something, they want to be involved, they want to, be very active as we all do when we're parents and whatever we can do to help our children. But I tell them really, during the cast phase of treatment, they're passengers. They need to do two things. They need to show up to clinic when we ask them to for their cast change. It's very important that we do those timely weekly cast changes because we're basically, by doing those casts, putting all those soft tissues on stretch, which because of what we call a viscoelastic nature of biologic tissues, the more you hold them on stretch, the stretchier they become. And so placing a foot on stretch to the limits you can, and then taking advantage of that extra elasticity you've gained to get further correction is really important. So they got to show up for their weekly cast, and they got to take good care of the cast. That's really their job. And so, we spend a lot of time in the clinic talking about cast care. And the thing we worry about the most during the cast phase of treatment is the cast not staying in place or slipping off. As you can imagine, Maureen, when we mold and do these corrections, these casts are very carefully molded and applied to the anatomy of that child's foot. And we're applying pressure in some degree. It's not focal, it's distributed, but we're still applying it to very specific parts of the foot in order to get correction. And so if the cast starts to slip off because the child's kicking a lot, or the casts are dangling and gravity's hanging down, pulling down on them, then the pressure we've applied is in the wrong spot, and that can cause skin irritation, skin breakdown. Sometimes you have to, if it's severe, you may have to stop casting and revisit casting once the wounds heal. It's always harder to cast an older child. And so we tell the parents, gravity's your enemy. We can never have the legs just dangling and gravity pulling down. Grandmas are notorious for doing this thing where they love staring at the babies in their eyes and holding their head in their arms, and their legs are doing this. We don't allow any of that. Diaper changes is another thing, right? Anyone who's had a child knows the easiest way to do a diaper change is to pull those legs up, lift the butt off the bed, and slip the diaper now. But if you're pulling up on the cast, you can inadvertently cause it to slip. And so we educate them to kind of turn the babies to one side or another in order to do the diaper changes to avoid that. And then just keeping the cast as dry as possible. Accidents are going to occur. These are babies, they're in diapers. Urine will get on the upper part of the cast occasionally. That can be dry with a hair dryer on the cold setting. Really important, it's on the cold setting, because you use hot, you can burn a baby's skin. And then just notify us if there's any problems, because we can take care of the problems pretty easily, and we make ourselves available for cast change as necessary. Now, fortunately, cast slips for someone who's experienced should be relatively rare, very rare actually. But as people are gaining experience and how to put these casts on, younger surgeons, you might be a little more prone until they refine their technique. But that's what they focus on. And then the other thing they need to focus on is just having faith that we're going to get the feet corrected, because we will, and we can. And orthopedic surgeons, pediatric orthopedic surgeons are to a person trained to do this. And so there can be a lot of anxiety about the deformity.
Hmm.
oftentimes after they see the correction that we achieved just after one cast, they kind of breathe a sigh of relief. They're like, oh my God, this looked terrible last week. And now it already looks like a more normal foot outwardly. And so then the anxiety level kind of starts to drop off pretty precipitously. But we do a lot of anxiety management because it's natural for parents to have
Yeah.
anxiety. We know, we see hundreds and hundreds of club feet a year here at Scottish Rite, but for the parents, they probably haven't seen it before, and so it can be very concerning when you see that deformity in your baby.
Yeah, I think that's the emotional impact, especially during the casting portion, seems because you're just starting that treatment and I always say you're like the spectator, right? Like you're just watching at that point, and it's funny that you mentioned because you're like, you just want to do something. And it's like, if you just wait, you're going to be doing everything. So just hold on, hold tight, and you will have a really important role. So it's almost like if I could go back and tell myself, like, just that's the time where you kind of are able to relax a little bit. Because when you enter into 23-hour boots and bar, that's that's where things start to get a little bit more intense for you as a parent, right? Like that's where you
Oh, yeah.
really have to step up to the plate. So I think if I could go back and tell myself to kind of just relax and let the process unfold. But there is so much anxiety because it's just it's your little baby. It's a newborn and there's already such a huge learning curve there. So,
Yep, the roles completely shift after
mhm.
we're done with the cast phase of treatment.
Yeah,
Once we're in the brace phase of treatment, or we call it the maintenance phase of treatment, because we're maintaining the feet in a corrective position, that's where
right.
the parents are the most important people with regard in that child's life, with the, not that
Hmm.
they are anyway, but
Yeah,
specifically with regard to management of the clubfoot. That's really where the parents are everything. And during the maintenance phase of treatment, during 23-hour a day brace, where I still see our parents every month to
hmm,
do bracing adjustments, but really more to coach them, make sure they're doing okay. It can be
hmm,
very stressful when you stop casting you into braces, and that's another important thing. And I'm sure you're going to get to that and ask questions, but babies don't particularly like
hmm.
braces for the
Yeah,
first week or two of
yeah,
bracing. They
right.
get very used to having their feet in these casts surrounded by soft cast padding and plaster, and effectively they're like their own little personal isolation chambers for their feet. They're used to
Hmm.
not having anyone touch their feet. And then all of a sudden the casts are off and they're in socks for the first time and they're in braces and everything's different. And it's not a painful treatment bracing, but it's different.
Hmm.
And kids manifest that as fussiness and irritation. And the first thing you want to do as parents, oh my gosh, these braces must be killing the kid. We got to take them off. And that's a mistake, because if the braces come off when the child cries or fusses, they're conditioned very quickly to continue to fuss and cry because they
Yeah,
know the braces off. And that's where we kind of go down the wrong path, and the braces, you spend more and more time out of the braces and the child never lets you back into them. And that's where we start seeing recurrences.
right. So, on that vein, how do you guys help parents transition from that casting to that 23-hour? Like you said, it's such a huge adjustment, and it's not just for the baby, but it's for the parents too. Like, there's a huge learning curve for parents who are sent home with a medical device that they know nothing about, let alone had any interaction with, right? So, what do you guys do to help parents transition?
Well, first of all, we start talking about the critical nature and critical importance of the
Mhm.
bracing from the very first day we meet. It's a huge part of my kind of I say my informational lecture about club. In fact, it's the biggest part of what I teach parents during our very first visit together, is how important the braces are to the success of the whole treatment. We give them braces on that very first day. We show them, they feel them, they see them, they play with the straps, they see how the shoes disconnect from the bar, and then every visit subsequent to that we provide them with the braces, so it's not a surprise. It's not
Yeah,
like you said, this is crazy new. It's not a crazy device. It's pretty straightforward and
yeah.
simple, but it's something they've seen and felt
Mhm.
and manipulated every single week leading up to that point. And then every week that I do the cast, we remind the parents of how important the braces are. When it comes time to actually go into the braces, we not only and just discussing how important they are, but we just start discussing strategies. It's a little bit of a break-in period, and we want to make sure, just like we want to make sure the casts don't slip and cause skin problems, we want to make sure the braces don't cause skin problems. So we kind of teach the parents for the first week or two until they kind of really get used to them and comfortable, and we know that there's no blister formation or skin irritation, to take them off 4 times a day for 15 minutes each. Look at the skin. If there's any redness, we provide some silicone bandages just to put over those areas for padding, but the braces must stay on. And then we encourage them to come in and for brace adjustment, because the braces can be modified very easily by a trained orthotist to take away pressure points and shave down areas that are pushing a little too hard. We also send them down to our orthotics department, where we have a whole separate educational program showing, having the orthotist apply the braces and how the braces work, and then and kind of observation to make sure the parents are comfortable doing it. We mark the straps so they know exactly how much pressure to apply with the straps, and we our orthotists reach an agreement with the parent of, okay, this is holding the foot good, and parent might feel, oh, that looks a little too tight, but the orthotists know it's not, and they're suede straps and they'll stretch out over time. And so after they visit with the surgeon, they have a whole separate education session on that day. It's a long day for them to use the braces, but we know how important it is, and we want them to leave as educated as possible. In addition to that, we, of course, I think like most places, provide, both kind of written information about the braces, but also QR codes that they can kind of scan with their phones to learn about the bracing experience, and that includes some parents who have kind of been through the process before with success.
Yeah. I think it's one of my biggest pieces that I always say is, like, education empowers parents to feel confident. And if you can start the boots and bar feeling confident, which is what sounds like you guys, it's a lot to take in. Like, it's not like it's that there's a lot to take in, and there's a lot on the line, right? You're thinking like, okay, we've worked this hard, the surgeon's got the foot in the right place, now it's my job to keep it in that place, and I have to make sure that this is successful. And so what do you like hope that parents understand about how their role shifts from from the casting to when they're sent home with the boots and bar?
Yeah, I mean, you try not to scare anyone, right? We know, I mean, there's a ton of literature and good evidence-based medicine showing us that the number one reason for recurrence of clubfoot deformity is non-compliance with brace use. And so you hate to sit there and say, well, if you don't use them, then these bad things are going to happen. But the truth of the matter is that when the braces aren't used, either not used at all or really even not used the way that we prescribe them, then the risk of recurrence truly does approach, at least of some component of the deformity, really does approach 100%. And when recurrences occur, we have to start back at the beginning with repeat casting. Our goal is always not to operate unless necessary on a clubfoot, because we know that any surgery we do, even the small tenotomy that we have to do in 90 to 95% of kids, creates scarring in a foot that is already baseline stiffer than a normal foot. And any scarring takes at least some degree of motion away somewhere. And so we want to maintain as much motion as possible. So the problem with recurrences is the child's now going to be older, and they're going to be at the point where they're going to maybe want to be crawling, maybe going to want to be trying to pull to stand. Now, crawling you can do in cast, that's no problem. And casting doesn't really delay milestones, nor do braces for that matter. But it's a lot trickier when parents want to really enjoy those milestones when you're dealing with a child who's coming to the hospital every week and in cast. The other problem with recurrences is, they manifest, say it takes us 7 weeks to get the child's feet corrected and we start the bracing, and maybe we started at 2 weeks of age. So now maybe they're 9, 10 weeks old or something like that. Is if the heel cord tightens back up, which is usually the first thing we see in a recurrence, that's going to have to be treated with a repeat heel cord tenotomy. And now we're talking about a trip to the operating room, because a 3-month-old is a little too old to kind of hold down in clinic and cut one of the biggest tendons in the body in half. And so now we're exposing the child to anesthesia, and we know that's not good for the developing mind. We know there are studies that show cognitive learning issues potentially later on during like the middle school years and high school years of kids who had early exposure to anesthetics. So it's just, it's something we try really hard to avoid. So I do share that information in a non-threatening way with parents, just trying to tell them about all the bad things I've seen time and time again, because I wish every parent was compliant, but they're not. And it's just, it just adds a whole other level of stress to the family. And especially having to go to the operating room, that's just, that's a real bummer for everyone if we have to take a 3-month-old or a 4-month-old or a 5-month-old and give them a general anesthetic.
Yeah. So are there misconceptions that you hear from parents or just from the Clubfoot community at large about Clubfoot treatment? And if you hear those, if you hear a parent talking about it, how do you approach that in an appointment?
Yeah, I think, there's a lot of information spread on social media. There are a lot of parental support sites, and you want parents to reach out to other parents.
Right.
That's important. When we have parents who want to reach out with other parents, we have a list of parents that are more than willing to talk to a new mom or dad about the whole process, because they've been through it and they know the system, and they've been through what is the true kind of Ponseti method and a bracing program that's based on evidence-based medicine. For the parents who go out into the ethernet there and are on these, they're typically getting advice from other parents who maybe they got their information from their surgeon. Maybe it wasn't an orthopedic surgeon. There are podiatrists who aren't exactly trained the same way we are who will try to manage these things. And so the information isn't really vetted in a way that's based in science. And we get a little bit concerned about that. The common misconception, I wouldn't say it's misconceptions, it's just different ways of approaching the issue. It asks a lot about why can't we use short leg casts, right? Clubfoot casts all the way up to the thighs with the knees bent. So you get pushback sometime of, well, this is just a huge inconvenience for us. We don't want the cast that high. They worry about some rubbing on the thighs. But the truth of the matter is short leg casts are far more likely to slip. This is a tiny little foot. Remember, it's pointed down when you start. And so the reason we go above the knee is really so that we can control the foot and keep the cast in place. So I do get some pushback about because there are some folks out there who try and do this with short leg casts. Now that's not the Ponseti method. And so we have to kind of dispel that and instruct them into the importance of going above the knee. I get a lot of questions or concerns about material. Your Ponseti method involves the use of plaster of Paris. It's moldable. It's the only way you can feel the child's anatomy through the casting material. Things like soft cast, which is like a kind of fiberglass type product that can be removed at home, is used at some places because the family wants to, say, take the cast off the night before a visit and give the child a bath, and they think it's going to make their life easier. But any time out of the cast, when you're relying on stress relaxation to immediately take advantage of getting more deformity correction, allows that foot to turn back into a position we don't want it, and takes away all of the work that was done the prior week of casting in increasing that flexibility. So if for true practitioners of the Ponseti method, plaster is the only way, and it's removed immediately before the next cast comes on. So I hear you have to dispel you have to have those discussions as well about a material or when just by virtue of when the cast can be removed. The other, it's not really a misconception. I mean, there's a whole lot of misconceptions about the brace phase of treatment. There's a
Mhm.
whole lot of devices that I believe are marketed to families as being more family friendly or somehow easier on the child,
Mhm.
that don't have scientific research to support their use and support their efficacy.
Mm.
And so anytime a device is marketed to a family that's very expensive, even if the family wants to pay out of pocket for it, we have to talk them down from that. And I insist on using a bracing device that's has proven efficacy. And
Mhm.
so a lot of the newer stuff on the market is kind of has been conceptualized in a way that maybe it could work, maybe there are some advantages, but unless it's proven time and time again over the period of time that the
Right.
Ponseti braces have been proven to be effective, um, you really don't want to go down that road. You want to use it, this is medicine, and we practice medicine based on evidence, and so you want to
Mhm.
use something that's got evidence to support it. But the other misconception, and it's not a misconception, I would say it's more a concern, is that somehow these club feet are going to cause a child disability or problems later in
Mm.
life. And that's not the case. When the treatment goes well, these kids do absolutely every other child does without any limitations, any restrictions, any job, any sport, even sport. There's plenty of people can research on the internet who are,
Yeah.
professional
Yeah.
athletes, make millions and millions and millions of dollars a year, who are treated with the Ponseti method. So the sky's
Mhm.
the limit for these kids. It's not really a misconception as much as it is maybe a fear.
Yeah. Yeah. Yeah, you mentioned that earlier about the developmental milestones, and that's something that comes up a lot in the parent groups is parents' concerns about whether the casting, the boots and bar are going to delay their milestones, whether that's rolling over, pulling up, crawling, uh, to all the way to walking, right? And so, what do you think?
Yeah, I spend a lot of time talking about this because we haven't seen it and we
Mm,
haven't published anything, but there will be some stuff that's forthcoming showing that, typically at the point where they're starting to hit developmental milestones, they're well out of the kind of cast phase of treatment and well into the brace phase of treatment. But
mhm,
our experience has been, and some preliminary stuff we've looked at has shown, that the braces do not delay the child's ability to roll over, to
mhm,
sit up, and sit independently, to crawl. Children can crawl in the braces and do so when they're ready, to
mhm.
pull, to stand, or even to walk. I mean, there are parents who are very strict about which I like. I like parents who are really strict about the bracing program, but typically my personal protocol is that once the child is consistently pulling to stand, there and kind of thinking about cruising, that's a great time to switch to nighttime only wear so that we untether their legs so they can
Right.
move one in front of the other. But
Mhm,
there are parents who said, no, I want to do this for a year, and their children will actually cruise and take steps with the braces.
mhm,
Milestones don't come, and this is just basic medicine. Milestones in motor development and gross
mhm.
motor skills don't come from the position the feet are in. They come
Yeah.
from centers in the brain and development of the brain.
Mhm,
And and a perfect thing to look at is kids. We take care of a number of kids from third world countries who never had their club feet treated. And they have completely untreated club feet, at the age of 5 or 10, or recently a young man who's 28 years old. Those
wow.
kids still do everything. They met their
Mhm,
milestones. They walked, they crawled, they still, some of them kind of run with their feet upside down.
mhm.
The issue comes down to when you're walking with your feet upside down, you can't really wear shoes, and there's the pressures being applied where it's not
Yeah.
supposed to. It becomes a painful type situation for those kids. But no, I firmly believe that bracing, or casting for that matter, doesn't delay developmental milestones.
Yeah. Yeah, that was my experience too. Like, and that's what I've heard so many people. I think it was easier because my daughter was our third, and so my older two, I kind of already had an idea of when these things were typical development for them, but also knew that there's variances in every child. And so I think it's easy for you to get into that mindset as a parent, like, well, they're supposed to be doing this by this amount of time. And then if they're not, that means something is off. But the reality is that all kids develop differently. And so you have to constantly be thinking about that and being flexible in your expectations of when things are going to happen, and know that every child is different, and it's not like you said, just about the clubfoot. There's so much other things going on. And for us, that really helped because I already had an idea of what was normal and for us. And then, I mean, the reality is our cutie kind of met everything faster than her older two sisters did anyway. So it was, it just, and that seems to be kind of the consensus within when you hear from the community. But when you're a new parent who's trying to conceptualize what impacts this is going to have on your child, that's one of the things that I think a lot of parents are thinking about. Like, are they still going to be able to do all of the other things, or all the things that I think they should be doing? So
yeah, we just, in our idiopathic cohort, we just don't see kids, who are being braced have, statistically significant differences in
yeah.
hitting any of the standard milestones than kids without. I mean,
Mm.
sure, there are going to be kids with club feet who don't start who never crawl.
Yeah.
Both my kids never crawled. They just
Yeah.
started walking, and they don't have club feet, and they just didn't crawl. And we're like, what's wrong with our kids? Something's
Yeah.
wrong. But then they just get up and start walking one day. We're like, all right, well, I guess they just skipped that whole phase. And
Yeah.
there are kids who don't have club feet who don't start walking until they're 16 months old. And as a medical community, we don't worry about that. We don't consider that developmental
Yeah.
plan. Of course, there are kids who have club feet who start walking later as well, but that's if you look epidemiologically, if you look at the whole population, they're all within the spectrum of normal, and so you just can't chalk it up to braces at all.
Yeah.
But I understand the anxiety, and that I think for most clubfoot providers and surgeons, again, when they're hitting those milestones, we're still doing monthly visits. So we've got an opportunity every month to dispel any anxieties and fears that those parents might have with regard to that. And then if hearing it from, the person who's treating it, or sometimes people say, well, the doctor just wants to give you good news. If they still have concerns, then we plug them into a trusted parent community to kind of talk to other parents who have been through the experience.
Yeah. Yeah. I think that's so smart of you guys, because it's such a balance of trying to give a lot of the information, but also dispel some of the anxiety and calming that. And it's a balance to try to find the right fit for that education with not overwhelming. It can be a tricky thing to find, right? Because you want the parents to feel successful so that they feel confident to continue throughout, because it's a long journey. It's not, like you said, a 2-hour surgery and then a recovery and then we're moving on. It's years of diligent, consistent work on the parents' behalf. And
the parents work so much harder to keep the club feet corrected than we work to get the club feet corrected. And you stress the kind of team nature of this is a team effort, and it's the surgeon and the person who helps him or her roll the cast, and if you're lucky enough to have a child life specialist to keep a child relaxed while you're casting, and yes, they're taking more of the lead role early, and the parents are still very involved in taking care and cast, but then the role shifts, and the parents are the most, they're the captains of the team. We're going to be there to support them and monitor their bracing compliance, and say, hey, I don't know what happened. We looked at some data here, and it looks like maybe last Saturday, would you guys go out on a date? Grandma watched the kid, took the braces off. You can identify stuff like that, but they're the captains of the team, and then we kind of fall into the more coaching and support role to make sure we give them all the resources and all the support they need in being successful with the bracing.
Yeah. Is there any advice, like what's your favorite thing to tell parents?
Oh, I mean, my favorite thing is to tell them that, you're going to be amazed that they look at this deformity. It's just such a dramatic deformity. You
Right.
can't imagine, and you just can't imagine. It's one of the most outwardly dramatic deformities we see in pediatric orthopedics. I mean, there's some, there's certainly other things and syndromic things, but I mean, this is a 1 in 1,000 incidence. Clubfoot is present in 1 in 1,000. That makes it extremely common.
Yeah.
And so for being that common and being that dramatic, parents come in under the impression that their child is horribly deformed and there's no way they're going to lead a normal life, and they're not going to be able to wear shoes that they want, or wear high heels to the prom, or wear those soccer cleats or hockey skates or whatever it might be. And so, there's nothing better than just tell them, just wait 1 week. You're going to see how good this foot looks. And you're going to quickly realize that this child is never, ever going to be limited by this foot whatsoever. This is not a disability. And sure, it might always be structurally abnormal on the inside, but it's going to look normal, if not really close to normal, and function completely normal on the outside. And so that's looking at the deformity and then hearing you tell them that, sometimes it's hard for them to believe you. But as they start to see the foot come around and correct, and you realize that they are realizing that, oh yeah, no, this really is going to be, my child's not horribly deformed. They're going to live a normal life and not be limited ever in any way by the foot. Is a really kind of nice thing.
Yeah, I can imagine. It is hard to compute when the visual aspects of the deformity are just so, and if you've never experienced it, you're like, as a parent, you're like, whoa, like the idea that you're telling me you can like get this foot through some casts, like they're gonna some of my favorite photos are of like just the progression of week to week, and then you put them together and you like do a collage and people are like, it's just mind-blowing. And in that vein, it's like I'm about to take my 5-year-old clubfoot cutie to gymnastics, so the things that I thought when she was diagnosed in utero I would be worried about now have it's not even a question in my mind. I'm like, we're going to soccer practice, we're going to gymnastics. You're able to do whatever it is that she wants to do. And part of the beauty in that is that, like, I know that I had such a big role in that. Like, I did my part. And so now that I get to see her really shine, it's like there's so much just gratitude and feeling of just excitement that was, in a team effort, but like so much of that was done by parents. And
you reap rewards of all the effort you sowed in the beginning. And of course, none of us as parents ever expect our kids to thank us for anything, but it's but they don't, you're doing it at an age where there's no recollection
that's right
whatsoever. But it is there's only a handful, maybe 2 handfuls of things in the entire medical world where parents can have such an impact as part of the treatment team for something that's so outwardly obvious. And when you honestly, one of the coolest things is when the parents like kind of come in at maybe the 6-year visit or an 8-year-old visit, and they kind of they're like, why are we still coming in? They almost forget in some ways that the foot was ever as abnormal as it was. And I'm like, well, we just kind of keep an eye on things. And they're like, yeah, but I mean, he's doing 3 sports and never pain. And I don't know, do we really still need to see you? And so it's like, yeah, you forgot. That's great. That makes me very happy. The other thing I'll tell you that's a very happy day is the day we stop nighttime bracing. That's kind of taken a page out of the book of our colleagues in the oncology world. And I remember my wife was treated for cancer, and when she finished her chemotherapy, she ring the bell. Everyone applauds and cheers, and the whole clinic kind of celebrates that. So we do our own little celebration in our clinic on the day that we finally stop the braces, the nighttime wear braces. And I think that's always a fun day for everyone.
Yeah, I love that. Yeah, it was such a big deal. We threw like a huge party for our cutie with all of our friends and family and made like a big deal out of it, because it's something to be celebrated. Like you said, it's a huge accomplishment for not just the kid, but for the parents who are really the ones putting in so much of the work while the child, wore it, but wasn't the one making the decision to put it on every night. So,
Yeah, there were a lot of hugs that day, and a lot of, really us. It's really for us to show appreciation of the parents
yeah.
for the immense role they played
Mm,
in getting the foot or keeping the foot corrected. And so we hammer them about how important the braces are. And we do like to have a little
yeah.
celebration when they've made it through and been successful with it, because it's just, it's every night, it's once you get out, it's 23 hours a day, and then it's every night. And it has to become a habit, and it has to just become part of the routine. And it,
Yep.
you
Yep.
know, I'm supposed to take a medicine every day, and I can't be, I'll be honest with you. Like, there are days
Yeah.
and you're like, we're not engineered to be
Yeah.
perfectly compliant people as human beings, but these parents, I mean, it just shows how extraordinary they can be when they become fully invested in the treatment.
Yeah.
It's worth a celebration.
Absolutely. It's so interesting because I think even today I was just thinking about how for 5 years of my life, Clubfoot was, I mean, a top five of something I had to deal with every single day. And now we're 8 months out of Boots and Bar, and I'm like, oh yeah, it's so crazy how quick it changes because it was so all consuming. But then you get to a point where you say, and you're like, oh yeah, you almost like forget that that was part of your journey, which I think is very typical of anything that you struggle with in early childhood development, right? Like the things that you were like, I was so tired I couldn't even remember what was happening, and now you're like, oh yeah, I remember I was tired, but it's not to that extent. So Clubfoot, I like to tell parents, like, you will get there. There is the light at the end of the tunnel, whether you can see it or not. It's there. You just got to keep moving inch by inch, step by step, day by day to get there. And when you get there, the light's real bright. So,
Absolutely.
yeah.
It's awesome.
Well, thanks so much, Dr. Riccio. It was so great. I am so grateful for your time and just your expertise and talking to us today. I think this is going to be such a great resource for parents. So I really appreciate you being here today.
Thanks for having me, Maureen. I enjoyed it too. Thanks so much.